This panel uncovers the strategic insights, the barriers, the breakthroughs that can drive mutual transformation across the borders. Please welcome Ms. Alka Goel, founding partner Alchemy Growth Capital, Commander Navneet Bali, Executive Director and CEO ClearMedi Healthcare, Dr. Jitendra Barmecha, SVP Chief Information and Digital Strategy Officer, SPH Health System, New York, Dr. Febi Ibrahim, EVP Chief Strategy and Innovations Officer, Memorial Hermann Health System, Texas. Moderated by Mr. Vishnu Saxena, founder and CEO, DHN and Scale HealthTech. A huge round of applause for the last panel in the series.
Good afternoon. All right. So this is going to be very exciting panel. And the whole reason, the whole idea of DHN forum is to do the cross-pollination, wherein, the leaders from India, they can learn from the leaders from the US. And leaders from the US, they can learn from what India is doing, from the Indian leaders. And the idea is that, like US and India, one is largest democracy, one is oldest democracy. And there's a lot going on in both countries. There are certain similarities. There are lots of challenges. So what we are going to talk about is with the four amazing speakers here. They come from like hospital background. They come from like VC community, and the kind of the perspective that we want to share with you. And so that is something that we are all very excited about. So with that, I want to let everyone please introduce about yourself really quick, and then we'll get started. Dr. Febi?
Hi, I'm Febi Abraham. I lead strategy and innovations at a large health system in Texas. Nice to be here.
Hi, good afternoon again. My name is Jit Barmecha. I'm a practicing physician and Senior Vice President at SPH Health System with few portfolios beyond IT and clinical engineering.
Hi, my name is Alka Goel. I'm the founding partner of Alchemy Growth Capital, an early-stage investment firm focused on healthcare, consumer wellness, and immediate adjacencies.
Thank you very much. Honored to be here. Thank you, Vishnu. Thank you, DHN. I'm Commander Navneet Bali. I'm the CEO and Executive Director of ClearMedi Healthcare. It's a Morgan Stanley invested company. We run Tier 2, Tier 3 city hospitals focusing on oncology. I'm also founder of an AI company called Medemildit.ai, which is in the US. It basically deals with health insurance. Thank you so much.
Excellent. So let's get started. Dr. Febi, if I have to, just look back last like 14 years, how the US healthcare, got unleashed on the digital transformation was the result of HITECH Act, which was passed around like 2011. That did two things. A, it asked hospitals that, hey, you got to adopt certified meaningful EHR technology. And then on the other hand, it asked healthcare software firm, the EHR software firm, that, hey, you need to improve. You need to make sure that your EHR is certified. There's a standardized. So you got to have a meaningful use, but a meaningful use too. And previously, of course, the faxes, unfortunately, the faxes are still there. So that spurred the culture of digital in the US healthcare. All the digital health transformation, slowly, then we moved from the regulated era to more outcome-based model, value-based model. And then, of course, lots of software companies have started to come in, lots of innovation started happening. So basically, that led the foundation for the US healthcare, where it is today now. Now, if you see, and of course, we call it achieve, it used to be like triple aim of the healthcare, quadruple aim of the healthcare, now the quintuple aim of the healthcare, right? Reduce the cost of care, better patient experience, better clinician experience, reduce the, better population health and health equity. So this is where how the US, got where it is. If we have to, contextualize this in the Indian context, how do you see that fits? What are some of the components that potentially can fit or not fit? So how do you see? I mean, can you enlighten in terms of how the US got this journey, and what potentially India can learn from it?
So I think what the HITECH Act and the Affordable Care Act ended up doing was really accelerate a couple of things. One is the digitization, as you mentioned, Vishnu, of the entire industry. Before, there were a lot more things happening on paper, and so we moved from paper to pixels to bits, and so that transition was helpful in at least getting a lot of the ecosystem away from the more traditional paper-based to the digital one. At the same time, the second thing that happened is there was a focus on innovation on total cost of care. So when Vishnu talks about Quintuple Aim, for those in the Indian context, Quintuple Aim stands for five. The five things in Quintuple Aim are: number one, outcomes and quality of care. Number two, it's the total cost of care. Number three, it is the patient experience. Then it's the provider experience and health equity. Those five things. It sort of dimensionalized those five as the pillars of a true value-based system. And what does value-based system mean? That you're not just focused on outcomes, you're focused on outcomes and total cost of care, which, as I mentioned earlier in the day, is unsustainable in the US. And we led, what that led to was a bunch of innovations that trialed how best to sort of reduce total cost of care while delivering good outcomes. And so that was the things that the HITECH Act, as you said, ended up doing. What India can learn from those is, I think those two are important factors. So if I sort of unpack it, I'll talk about the things to keep and the things to avoid. In the things to keep, I think India is on a fast track of digitization. So that's one of the things to keep. The things to avoid would be, in the US did not really pioneer a standard for interoperability, that because a lot of care is fragmented, it's still an issue. And so we're not able to sort of fully architect our way out of it. So India has an opportunity to define the standards, perhaps with regulatory and policy push from the government to say what is the right framework for digitization, and let private capital flow into developing the equivalent of EMR systems, EHR systems that can then go deliver it. But then also, because India has many of the same feature sets as the US in terms of fragmentation of care, it's not highly concentrated, it can learn from that. The second thing to keep is an outcomes-focused assessment with a total cost of care mindset. I'll give you an example of this. When you build a house, right, the person who constructs the house, your builder, will tell you what's the floor plan and how much it costs. In the US, I made a doctor's visit 2 years ago. I still get bills on it. I don't know what the hell I'm paying for, right? And the whole care journey, from the first primary care visit to the specialist visit to the diagnostics to the hospital intervention, that whole package is not available to the patient. So I think the more we can think in terms of journeys, and the more we think about the total outcomes and get the patient educated on it, the better off we will be. That has, at least the outcomes logic has come in terms of how it's measured for payments purposes in the US. But that what I think can be avoided in India is the lack of transparency to the patient and the provider. It's still an opaque box for them. So I think that's the dimension that I'd like for India to sort of discard from the US while keeping the outcomes focused at the front end.
Yes. What? Well, I think I like the way you very strategically, like the price transparency is important, but of course, when it comes to the outcome kind of things, that's something that they can potentially avoid, or because it's too much to handle. Dr. Bali, I'm gonna go straight to you. Oh, sorry, Commander Bali, I apologize. You run a successful chain of care delivery organization, urban setting, suburban setting, And when you see India, I mean, we have done, like India has done over last, I would say 7-8 years, pretty good when it comes to creating a data infrastructure, democratizing data. Of course, there was an intention, there was a lots of effort went into it. I mean, we used to talk about interoperability when I started my healthcare career way back in 2011 in the US, 2010, 11. The interoperability, of course, after the High-Tech Act became a centerpiece. We are still talking interoperability. We are still struggling with the interoperability. Now, with the NHA, with the National Health Authority here in India, with the ABDM and UHI and all those kind of things, with kind of the Aadhaar 5, there was like 538 million. I'm actually may not be as accurate, but it was close to that. So India has done certain things well. Of course, the adoption is we are a large country, we're the most populated country, and of course, we have our own challenges. Where do you think the US can learn from India's highly efficient ways to create the data backbone?
Yeah, thank you, Vishnu. I just want to contextualize certain things for the sake of the audience. A comparison between US and India as we stand today. So the US spends close to 12% of its GDP on healthcare. India spends around 3% of its GDP on healthcare. Almost 70% people in US pay taxes. 2% of people pay taxes in India. The tax to GDP ratio in India, in the US is almost double. It's almost 24% compared to around 11.7% in the US. Then we have 140 million people who have to be taken care of, and we are the most populous country in the world. So the journey which US undertook and where it has reached today, and the journey that India is at right now, and where it is going to land up tomorrow, it's going to be very similar and very different. It reminds me of the French Revolution. Also, very importantly, when you sit inside halls in cities like Delhi, you actually are not able to gauge what truly Indian healthcare is facing today. For example, I'll give you, we have a hospital in Nanded. It's a small place in Maharashtra. The only cancer hospital in Nanded is run by us. Sorry. The machine, the linear accelerator, which gives radiation to patients, starts at 4 a.m. in the morning and goes on till almost 10 p.m. at night. Almost 100 patients are treated on the couch every day, and most of these are Ayushman Bharat patients who are the free patients. In the place called Goraj near Baroda, the tribals of Madhya Pradesh, Gujarat come and get treated there. 3 machines treat almost 250 patients on couch. So the moment you travel around 2 hours away from Delhi, Mumbai, Kolkata, the complete healthcare scenario in India changes. And what is the beauty is Ayushman Bharat, whatever stage it is today, we have a lot of grouses against payments, deductions, etc., etc. But let me tell you, all the patients who are coming to these centers in Nanded and Goraj and many smaller cities and towns would have died of cancer for sure, would have never ever got treated. So one of the most beautiful things that has happened to us is something like Ayushman Bharat has been thought of, has enough problems of its own. It's not such a great solution as we see it today because there are delays in the payments, the rates are not well defined, etc., etc. But I think this is one such system. I think next 5 to 10 years are going to be very, very crucial. Also, India has a very, very young demographic profile right now. 140 million people falling ill or a part of it getting into hospitals is never a solution for Indian healthcare. The solution for Indian healthcare is to keeping these people out of the hospitals. So preventive healthcare, which is a part of this entire ecosystem that we're talking about, is massively skewed towards the direction in which we should going. So US is an advanced country, a lot of respect towards that country. They've done some very, very great pioneering works. But one thing which I think US can learn from India would be the prohibitive cost of treatment in the US, which despite the fact that we're a very, very poor country, we have a very small tax to GDP ratio, we have very, very low this one, but still we have kept the cost of care to be extremely, extremely low. We have the finest doctors in the world today, whether it's in the US or in India. And the other part of the story is about the journey that US has already reached as far as data is concerned, we are now starting in earnest over it. If you're, someone mentioned IBM Watson a few panel discussions back. There was a program which IBM Watson made that was on oncology, medical oncology. Trying to help the medical oncologists in taking decisions, but the entire data was Caucasus. And, it failed in India because people said that the data is Caucasus, cannot be used in India. But believe you me, all the medicines in medical oncology today used, the research is happening in these countries and not in India. So I think we are on that path towards a more inclusive ecosystem towards our population of this massive, massive population, taking a huge number of people together towards a healthier nation tomorrow, keeping the costs to be extremely low. I think these are certain things that US can certainly learn from us.
Beautiful insight, Commander Bali. Totally agree. Very well laid out. The quality of the outcome and the efficiency and the example that you gave, the scenario that changes, just go like an hour from any major, metros from within India. And I think, so totally agree that those things certainly US can learn from India. Coming back to you, you are at the intersection of, the VC community. And of course, you learn one of the successful VC fund in health tech space and the world of the startups. When you were in McKinsey in the US, and of course you see highly matured VC model. I mean, there's lots of solution. Fabi runs, like $500 million US venture fund. They got like 52 companies. So well matured. Hospitals have incubation center, inside out. They spin out the companies and all. So what's your take? How do you see what you want to adopt? What you would like US to adopt from India, and what you think India to adopt from US?
Thank you. Everyone touched on a little bit of the fundamental differences. That it's like Mars and Venus, the healthcare system of the US and India. Obviously, people talked about 20% of GDP spend now being almost close to $5 trillion for healthcare in the US, whereas it's a small fraction here. It's a very, very organized industry there. I mean, the top three distributors are 97%. Relatively speaking, though fragmented, hospitals are still more organized, whether it's labs, whether it is information companies, whereas India is very, very fragmented and the ownership structures vary. The insurance industry is completely different, as it's employers and of course the government. Ayushman's coming in, but many people uninsured, OPD completely uninsured, outcomes-based is a joke here, right? So we as VCs, I think we can teach India a lot, US a lot about frugality, which you mentioned. I don't understand why everything in the US costs 20 times, 30 times, 40 times more than what it costs in India. The cost of goods sold, even the RT-PCR test, when I was in the US and I had to get it done, I think it's $250 USD, at least the place where I got it done in New York. And here it was, $6? And I couldn't understand because the technology was the same. So there's massive inefficiency, and it's just building upon each other and fair amount of bureaucracy. I think what India can learn is clinical innovation and use of data. People are very scared to try new things developed in India. Somehow there is still the colonial mindset of if it is discovered there, it's probably better. There is some truth to that, given the processes that are followed, the data that is required. But I've seen physicians almost very hesitatingly wanting to accept clinical innovations, and we as VCs are very eager to fund these innovations. But if the buying community doesn't want to adopt it, it becomes very hard. So how do we give faith to our own innovators? We see systems like so many accelerators, incubators, and they may not be perfect. So how do we as hospitals take a chance on them? Which I come back again, because it is our obligation to give them those validations, to give them the patience to try out things and actually take a chance. So I think this whole mindset towards innovation. I must say, since COVID, there is a little bit of a change, especially when it comes to med tech. We are seeing many new companies because it doesn't require the very long trials. Developing things, it could purely be, hey, same product but lower cost. So we are seeing that. So it's encouraging. But we had a company which is doing some innovative work in cancer, and no one was willing to look at it because, hey, we don't understand the science and I can't take that bet. In the US, there are so many VCs that are fully dedicated to taking risky biotech bets, which doesn't happen here. I don't know what's the cause and the effect, but we could learn innovation and they could learn frugality and efficiency.
No, I think that's clinical innovation. Great idea. Looks like the time's is up, but I really need to hear, Dr. Barmecha. I can let you go without you share your thoughts. You are a long-term CIO at the one of the greatest city on the planet Earth, and you have implemented lots of technologies. You have seen policies implemented through technology. If you have to advise one thing to NHA, ABDM, what that would be, and what you would like to bring it to the India.
I don't think I'm in a position to advise Ayushman Bharat and all their peripherals. Yes, I have been in IT for a very long time, darker side on IT for last 11 years, and I used to be the CMIO, which is the clinician in the IT department. Nobody liked me anyway. One thing I can like Fabi and I, we were discussing what US can learn. I think UPI. I think it's people don't realize how powerful UPI is in terms of transaction with a standard, and US can definitely learn a UPI of interoperable health standards. So wherever the patient goes from one state to the other or globally, the accessibility of the health records are there. Number two, I think digital twin. We did not discuss today too much about digital twin. It is a very powerful digital tools. For example, I practice medicine. The information I have in front of me, either from my EHR or from other EHRs where the patients have been, is only 15%. So you need at least 85% of more data outside of your EHR to take a holistic care of the patients. So in terms of learning from either US or India, I think the concept of digital twin from other agency, whether it is environmental agencies or food industry or anywhere else, that digital twin, including the behavioral health, how we shop, how we eat, where the producers are coming from, those type of data, when it comes together and act as a digital twin, can be very, very powerful in terms of providing holistic care. And last but not the least, I cannot emphasize enough, whether it is India or US, right now we get paid when the patients are acute, patients need surgery. These are all fee-for-service based, and these are all on the acute side. Nobody pays for wellness. So I hope in future both the countries can focus on wellness and prevention from the birth. Not when you are 21, you are buying your Apple Watch or Fitbit or whatever. It needs to start from schools, needs to start from preschool and focus on wellness. That is the only way you can bend the cost curve here.
Totally agree. Any question from the audience? Any question? Anybody? Yes. Sure. Yeah.
Yeah, I just want to take from what Alka has said, and this is throwing it open to all of you and to your children and to whoever you are. At least in Clear Medi Healthcare, I was in ISB a few days back. I said, if you have an idea, you want to do it, whatever you want to do, I'm not going to be the one who said that our data cannot be taken. All that is absolute rubbish. Please feel free to connect with me or to my people. We are throwing open our hospital chains for your research and any idea that you want to have, because if you're not doing that in India today, we're not going to be there anywhere. So my request to all of you, if you have an idea, have a startup, have something where you require data, please feel free to talk to me or talk to my team. Thank you.
That's amazing. Round of applause for Commander Bali for that. Great. Please.
I think my back is how to take the kind of boldness or generosity which Commander Bali is showing, because it's not going to be just one hospital that, like, or a few hospitals sharing. It has to be something which becomes like maybe some kind of a regulatory compliance that kind of leads to the data integration that we need to see happen. So interoperability in terms of data collection methods can be there, but unless we have that kind of a platform which brings together the data sets from different cities, from different hospitals, from different streams together to kind of get the kind of data set that we need for robust statistical analysis, I think, what would you say can make that happen? I think that's from the big picture view, that's who can make that happen, I think.
Vishnu, can I take a shot?
Please.
So there are two ways to make it. One, you have a mandate. So in US, there is a mandate for National Health Information Network or the State Health Information Network. All the hospitals or health systems are required to contribute some amount of data. So that is one on the public side. And on the private side, Epic is the largest EHR. In terms of volume, what they have done is they have taken patients and they've created a database called Galaxy, which is the largest human database for research purpose. So it can come from both public side as well as from the government side. So if any EHR company, for example, eClinicalWorks, I'm not doing marketing for eClinicalWorks, but if the EHR company like those which have a very large market share in this country, they can gather those data, de-identify those data, and then do some public research. But on the other side, there has to be some kind of mandate. In US, after banking, healthcare is the most heavily regulated in the service industry.
So, in addition to role of the government, standards, as well as the EHR companies, we've seen two other models evolve in the US. One is consortiums of health systems. So we've come together as health systems and said, look, for example, Houston represents 2.5% of US population. But then if I combine with Dallas and Chicago and Seattle and New York, I slowly get to 25 to 30% of US population. So how do we bring a lot of health systems together to sort of start aggregating that data that will also create diverse populations and therefore be able to add to the richness of data? And so we've created that kind of a consortium framework in the United States. That's one. The second is to truly understand what value the data is going to be adding and to whom. And I think one of the areas that we believe there is a disproportionate value going to be created is in clinical research and discovery. So we've targeted biotech and pharma companies because the more data they can get, the more personalized therapies they can develop, the more they can sort of do in health economics and outcomes research and so on and so forth. So we've also pulled them as sources of buying some of the data and creating the economic incentives for creating the data standards.
Would it incentivize the hospitals to share their data? Because it's like one question that came up is, why would the hospital want to invest in research? Because, they would need to put a lot of effort into setting up the data systems to enable that research. And there's no value to it as a hospital, at least unless the doctors are interested in the research papers that they want to write.
So we did not mention about the payer part. So there's a remarkable difference between the payer side in US versus India outside of CGHS or state-funded program. Because the third party is paying in US, they can mandate as well that if you want to have a contract, for example, United Health Group, which is one of the largest, they have the beneficiary in the country, they can mandate that if you have our contract, you need to give a certain amount of data, whether through claims or whatever those are. So again, some sort of regulation, some sort of mandate, whether it is through consortium, whether it is through the EHR vendor, I think the time has come. We need to do this, whether it is in India, globally, or US. Yeah.
So, and just to build on that, a lot of health systems in the US are also academic medical centers. We run an academic medical center as well, for example, in addition to our community hospitals. So you take Mayo Clinic, Cleveland Clinic, us, we want to be at the vanguard of clinical outcomes. So I'll take a specific type of hematological condition. In Houston, I may have hundreds of cases at best. But if I sort of expand that 40 times across the country, now I've got thousands of cases, and I now have more personalized evidence-based pathways I can develop. So it's not true that I just want to stay in my addressable market. The more data there is, I can serve my community and orient my mission even further by that explosion of the data. And we've recognized that we don't have the scale, and therefore working with other health systems with similar mindset, again, with the guidelines of de-identified data, help us to sort of explode our data set and therefore create a more differentiated clinical research offering, which then allows more patients to select us as the brand of choice when you have a complex condition.
A round of applause for the great panel and the great insights. Thank you so much, Dr. Fabi, Dr. Barmecha, Alka, Dr. Commander Bali. Thank you.